I think what I'd like to address, although I'm a fairly technical person, and this is working again, I want to show some slides that demonstrate why there can be a broad variety of response if people are being treated. You may have heard that some people don't do so well, some people stay the same, some people get a little bit better, and then there are the lucky ones who, like Diana and Steve and a few others here, I think, who manage to really recover a lot of their function. So we can't tell you if that's going to happen, but what we can show you right now is what we're beginning to understand, the potential of trying to understand that in the future, and there is a lot of research that needs to be done here, and one thing that perhaps I should say, and especially since Dr. Monty Harville is also here, who does interventions for other things, and Dr. Sal Sclafani from New York and Dr. David Hubbard from San Diego, is that there's a lot of people who have now been treated who are sending emails asking, so can we get re-imaged? Can we find out what did that treatment do? Are our vessels open? Do we have return to normal blood flow? These are probably very important questions, and I imagine the more of this that is done, the more people will start contacting this. We don't have an IRB yet to actually go and image those people who have already been treated. But this is probably a very important thing to do in the near term, is to start that process. IRB, by the way, is Institutional Review Board, or a Human Studies Approval. And you have to do that if you're going to scan people, do the quantification, and then report it in a scientific journal. That has to have IRB approval. I believe David has had IRB approval for some time now for his work, both for the imaging and the treatment component. So that's a wonderful thing. There are sites out there yet that are doing these operations, but they don't have approval yet. And so there's a lot of these early people, they don't have those questions answered for them yet. So today I want to go through a little bit of this with you here and see if I can use this. And this is a wonderful room. My heavens, you can look just about any way you want, and you've got a screen facing you here. So what I want to talk a little bit about today is the role of imaging, because I don't do any treatment. We image people. We develop the imaging technology. We try to produce data that Dr. Sclafani and Dr. Harville can use prior to having to go in and do this treatment. And then we're going to look at some future issues related to this as well. So the main thing for me is that the patients get an MR scan first. Almost, it doesn't matter what the treatment is. Could be drug treatment, for example. Whatever works best for you, you should have an MR scan first, because that serves as a control for you. You get to see what the condition of the brain is like at that point in time, so that if you come back a year later after treatment and you get another scan, and that treatment is working, you might see that there's no more lesions in the brain. You might even see some of the lesions have gone. You won't know unless you had that control scan. So just from a practical point of view, that's very important. The neurologists usually do have their patients get an MR scan, so it's part and parcel of sort of the normal diagnosis for MS people. Now, Zamboni came along about 2 years ago. He didn't actually make this public, remember, until about 9-10 months ago in September in Bologna, Italy. And he said that he had now done this study with 65 people, and he found that there were 5 criteria that he used to say there might be something wrong here. You might have chronic cerebrospinal venous insufficiency, i.e. you don't have enough venous drainage or smooth enough venous drainage, and it creates a problem. So one of the conditions was high resolution. A high resolution imaging method can find evidence of stenosis. So if the vessel narrows and you have the right technology, you can do it. He did it with ultrasound. I'm going to focus on the MR aspects of this, but probably Dr. Harville and Dr. Sclafani will talk more about the ultrasound and the treatment component. He also said that many times in these vessels, he found that the blood flowed backwards. Instead of flowing toward the heart, it flowed back towards the brain. Now, again, the question that I want to warn you about, because I'm going to show you mostly abnormal things, is that we're not really 100% sure what we should be seeing in normals yet. It's possible there might be reflux in normal people too, to a small degree. but probably not to the major degree that he sees, where he says that sometimes 50% of the cardiac cycle, so half the time that your heart is about to go from systole to systole, the blood flows backwards. Well, that's a pretty severe effect. I'm not sure I've seen that on normal people yet. And he also points out sometimes there's just no blood flow in the jugular at all. Other times he finds that there's reflux in the deep cerebral veins, and that could be the straight sinus, for example. And then finally, another interesting point that he can see with ultrasound that I can't do with the MR, because you can't sit up in an MR. But if you sit up or stand up, usually the blood flow in the jugular gets very small. And the vertebral vessels take over. When you lie down, it's the opposite. The jugular flow tends to get larger, and the vertebral flow tends to play a less important role. So he found that the people who went from sitting up to lying down didn't have such a big change in their jugular flow. And so that was a marker that there was something wrong there. Okay, so I wanted to give you that sort of global introduction. Well, here's an example of a normal person. And so, again, remember here that as you're looking at me, your left side is my right side. So when the radiologist is looking at these images, this is the right internal jugular vein from the left internal jugular vein. They're on the order of a centimeter or so in diameter, and they look pretty nice. And they should. This is a normal person. Now, this might be a little bit harder to see, but all of these little cross-sectional circles come because I took a picture this way, a transverse image. So if I have flow in a pipe like this and I cut it, I'm going to see the cross-section, right? So here you can see the cross-section of those jugulars. And they're very nice, they're very patent. There's no clear narrowing associated with them. So this is kind of radiology 101 at the moment, okay? So you're going to know a little bit on this by the time you're done today. And here's an example where we use these 2D images and compare with a 3D data set where actually we inject a contrast agent. The contrast agent goes into the blood vessels, and we take a picture this way, we call it coronally, so that you can get an image now of all of these vessels looking at them coronally. But we can also look at them this way. So what we do is we try to follow down through here, through the sigmoid sinus area, down into the jugular, and then further down into the jugular. And this area, this line mark number 1 is this slice here, and you can see nice big jugulars. If you go to slice 3, and you look where the jugular is supposed to be, there's nothing there, or at least we can't find it. It might be very tiny. It might be 0.5 millimeter in size or 1 millimeter in size. That would be good news if that's the case, because then Sal would probably say, well, I can probably get a catheter up in there, and maybe I can help open that up. So these are the types of data sets that we process. But we can do something else with these transverse images. If we, again, cut this way and look at these beautiful cross-sectional pictures here, I think it's obvious on the left-hand side. And on the right-hand side, you see these cross-sections are black sometimes and bright other times. So here, it's black, and black in this case means the jugular flow is going toward the heart. From the arteries, and they're flowing towards the brain. So if we go and measure what's happening inside here, we take this picture once about every 50 milliseconds. So we can get 20 pictures in 1 second throughout the cardiac cycle. So when that heart beats like this and then comes back again, I can catch that blood flow everywhere in those vessels at that time point. So, and at many such time points. So what we can do is we can make a plot as to what the flow looks like as a function of time. So here you can see the blood flow as a function of time. The units here are centimeters per second. This is for a normal person. And the flow is about 10 centimeters per second for the peak velocities down the jugulars and the externals and other veins that we have measured here. So that all looks pretty good. You don't see anything going negative here. And then, and many of these data sets, by the way, they're actually from fellow Canadians, for those Canadians who are here. Here's an example of someone who not only has this flow reduced to 0 for almost half the cardiac cycle, every one of her vessels goes backwards here, the whole system, and some of them go significantly negative. So this meets the Zamboni criteria. So this person, in fact, went to Bulgaria, and they have been treated since having had this imaging. So it is possible to use MR in a very complementary way to what Dr. Scavani would use ultrasound for, but I'm a little biased. I have to say this is better than ultrasound because not only can I get this at a pixel by pixel basis throughout the cardiac cycle, I can do it anywhere in the neck or the brain, and so it's not dependent on having a probe that you have to push against the neck or hold here. It's just line the magnet, take the picture. And this only takes 1 minute and 20 seconds, and it's completely operator independent. So just to show you another example, sometimes as an interventional radiologist, you would see something like this on the left-hand side. And you would say, okay, normal. Now, David, out of the 36 cases that we've looked at so far, we've found 6 people that look normal. At least when I looked yesterday, and 30 of them look like they might have anatomic abnormalities. So
the actual number was 25 out of 27 were abnormal.
Okay, but I'm up to 36. So in any case, and I'm not talking blood flow. I'm only looking at the magnitude images. So the point is this person normal? Well, on the right-hand side, you see a map of the blood flow that's going in the wrong direction. The red lines represent blood flow toward the brain. They're the arteries. The blue lines represent the blood flow for part of the jugulars. That should have been 0 everywhere here. But it's clearly not 0. In fact, it has a very large negative component. So, in fact, David, in the end, if you were to look at the flow component information, now it's no longer 6 normals. This person would not be counted as a normal anymore, even though anatomically he looked normal. So, reflux, I want to make a little comment about this. Reflux is actually rather complicated. So sometimes you can get the blood just simply shifting and flowing back up toward the brain. But there are other times that we see a circulatory effect. So we see part of the blood actually flowing down all the time on, say, half of the jugular. But on the other side of the jugular, for some reason, fluid dynamically that I'm not sure we understand yet, we can see the blood flowing back towards the brain. So there are times that we can actually see blood flowing towards the brain 100% of the time. And Zamboni noticed that, but he didn't really discuss this circulatory component. So those are 2 different conditions. Somebody who has reflux just because the blood starts to flow back toward the brain in the entire jugular versus those people who have the circulatory flow. So you can see this is a very complicated situation. There's probably no 2 people in this room who have the same type of venous pattern for the MS population. And as you'll see this as we go along here. So I want to show you briefly what you can get here. You can get, in MR, you can get a picture on the left, which is the arteries. And if we wait a little bit longer, we can get the arteries and the veins. And finally, at the very end, we can even see the small veins in the spine. And unfortunately, this is a little inconsistent, but you can see the small veins in the spine even highlight. So we can get a lot of data out of this to look at all these components of the blood flow in the neck. Okay, so I'm going to show you a case here where, because in MR we collect 3-dimensional data, so we basically collect something like 96 slices going from here to here. So these are, you can imagine, very thin slices. Maybe they're 1 millimeter thick. And if I look through the entire neck, it's going to contain a lot of blood vessels, right? It's going to be pretty complicated. So it's going to look something like this, or maybe something like this. And it's kind of hard for me to tell what's going on here. So I can just go and pull out a little region of interest, maybe just 1 centimeter, and I can focus in on the problem. And here you can see very nicely that buried behind all these other vessels is an area of stenosis. You can also see on this side an increased area of collaterals. And usually we find that the enhanced collaterals, that is the alternate pathway for your blood to get out of the brain, is usually the same side as the stenosis. So it's just like if you had to get off 94 on your way home and take a long route home on the side roads, you'd get home eventually. But it's a lot more tedious and it's a lot more energy consuming to do that, and that's what happens in some of these cases. Okay, now I'm going to go through quickly a bunch of cases because I talk too much. And I'm just going to show you some example abnormalities. So this is an example of a truncular venous malformation where the vessel comes down and completely stops. Here's another case where the vessel comes up and completely stops. 2 different people, 2 different problems. Here's a third case where the vessel comes from the sigmoid, comes down here, it wants to be a jugular, but it stops. And it turns out that the jugular is fed here by the vertebral veins, and actually it continues down as a jugular, but it's not sort of your conventional geometry. Here's another case that basically this person doesn't have any jugulars. Now, we don't know how important that is because neurologists will also correctly tell you that you can have certain surgeries where there's a jugular that's not working, and that person will be fine. So it may not be as simple as just saying you have a bad jugular. There could be other aspects to your vascular territory that are different enough from someone else who might have that lead to this problem. So this was a pretty severe example of a dual abnormality. In this case, we have a person who is a bit unlucky. They have multiple stenosis, one here, one here, one here. And I would like to thank Wu Zhen, who's in the audience here, for helping produce some of these slides. Without her, I would not know all the anatomy and things that I do. This is another example here of a vessel that is a long, thin vessel. So instead of having a tight stenosis in a narrow region, it's maybe like a string. It's 5, 6, 7 centimeters that it's being narrowed. This is a more dramatic example here. See, a very, very long, narrowed vessel. And I would assume that from an interventional radiologist's point of view, that every one of these cases I'm showing you might require something different. They're not all going to have, okay, that's nice, it's a centimeter stenosis, let's go put a balloon in it. So they'll all be a bit different. Here's in the case of an upper level stenosis. Now I'm showing this here in the next few cases to point out that where we see some of these narrowings, especially this type of case, because if we look at the vessel sideways, it's definitely narrowed. But it's more what we call pancake, because it looks fat from one view. It's kind of like, well, like this. If you look at it this way, it looks narrowed. If you look at it this way, it looks fine. So it's more like it's pancake. And Dr. Zamboni has pointed out that having some of these apparent stenosis in the upper regions, and even apparent stenosis by the confluence with the lower subclavian, i.e. right in this region here, actually can be caused by bad valves. And so if the doctor goes and treats those valves first, those stenosis might disappear. So this is an important piece of information, again, for the interventional radiologist to know that before you go and try putting stents in what looks like an abnormality in MR, you should be checking each part of the system one step at a time. Okay, I'm going to skip this. This is just another example. And you can imagine now every one of these slides I've shown you is another person. And they all have, well, most of them have these problems, right? For me, 30 out of 36 so far. Another example here, very narrowed region. This person actually has problems on both sides. This person has problems on both sides. So bilateral, lower level symmetric stenosis. Sal, I don't know if those are caused by bad valves or what, but you'd have to find out. And maybe you can address that issue when you give your presentation. This is a particularly, sorry, I'm not at the right one yet. I'm going to skip these. There's so many of the same things here that this is a lower level bilateral stenosis, but in fact, in this case, I think this may have been caused more by valves than anything else. So if you think about it for a minute, if the valves are blocked and there's no pressure differential from the upper to the lower regions, that system can just collapse. There's almost no blood flowing through it. So if I think I see a stenosis, it may not be because there's a narrowing there. It may just be because there's no blood flow through it. So we can take this data, and if this shows, and okay, usually it's up by now, so unfortunately it was a nice 3D rotating image. But those of you who have been to the website ms-mri.com, well, you can find these very pretty 3D rotating pictures there. This is a particularly interesting case because not only does this one come down and narrow and almost stop, it has this little trunk here, this truncular venous malformation. And if you were to go in this case, you wouldn't find this connecting. This actually connects to the external. So it's a very different type of geometry. We've seen this now 2 times out of 100 times. So not very common, but it happens, and it can be very complicated geometry. I'm going to skip through a few of these. This might be a different case. So I don't know if you've seen something like this. Woodzan has suggested that this is an enlarged thyroid, which is now compressing the jugular here. Again, I think this is the only case we've seen so far like that, but yet another reason that something could be causing a vascular problem. And there are a variety of other problems. So I'm going to skip all these examples. I finish in the neck, just to tell you that we're working on techniques that allow us to image the azygos in the spine. Sometimes we get pretty good results. Sometimes the results are good enough to say we couldn't even see any flow after this. So it'll be interesting to see how the angiography correlates with the MR in being able to say that that's a normal azygos and that's an abnormal azygos. Now, people who tend to have lesions in the spine also tend to have these azygos problems as well. Okay, so I'm going to switch for a minute and look at the veins in the brain instead and just comment to you a little bit about iron content in the brain. So this is an image that can be done now on most standard systems. Dr. Hubbard does this at his site. These are all the small veins in the brain. And you can see the thalamostriate veins here and what are called the basal ganglia here. And you don't really see any abnormalities in this normal person. Everything just looks like veins for the most part. And I like showing this slide, not that it has a huge amount to do with MS, but it's kind of fun to show it. Some people with MS tend to show that these vessels disappear over time. And the more serious you are, the less I can see them. The fact that I can see these vessels means there's a lot of deoxyhemoglobin in the blood, which means your brain tissue is working just fine. And so that's a good sign. In fact, this particular person had 2 cups of coffee, and you can see here that the veins that you can't see well here come to life here. And that's because he's eating up basically more. He takes the same amount of oxygen, but he has slower blood flow, so more iron is present. Not bad iron, by the way. This is just iron that's naturally in the blood. And now you can see this effect. So this technique is very sensitive to small changes of iron. And here's an MS case where you can see at the confluence of all of these veins coming out of these basal ganglial structures into the thalamostriate. This is where you see the iron. This was our first indication that the iron seems to follow a venous pathway back out those structures in the brain. So we can now go and measure that iron content. And if we do that in different structures, in this case in the pulvinar thalamus, we did this in 100 normal people. And all these little purple dots and blue diamonds are normal people. All the triangles and X's are MS cases. So depending on the study we've done, we find between 30 and 60% of MS patients have abnormally high iron content somewhere. So the question for us is going to be, does this go away after you've had treatment? Does this increase, over time if we were to image you at different points in time? So iron does appear to be associated with MS, and this is going to take a lot more research for us to evaluate. So I want to close by telling you a little story about Tracy Putnam. He's a very famous neurologist. I wish that he had MR scanners back then, or ultrasound, because I think he would have been the Zamboni of the 1930s, because he did a study on 14 dogs. And he believed that MS was caused by bad flow in the veins. So he went in and he obstructed flow in the small veins that I just showed you with those previous pictures. And these 14 dogs all developed sclerotic lesions. So this is a quote directly from his paper. He says, "The similarity between such lesions and many of those seen in cases of multiple sclerosis in men is so striking that the conclusion appears almost inevitable that venular obstruction is the essential immediate antecedent to the formation of typical sclerotic plaques." So this is, in my opinion, was the first hard evidence that changing the venous flow made a difference. And about every 10 years, for the next 70 years or so, people came along and found other reasons why the veins might be important. But unfortunately, that just never quite gelled. And it was really a combination of the modern imaging techniques that lets me show you these type of things today that really finally lets us go in and answer Putnam's questions. And although there's still a lot to do here, there's clearly venous involvement in this. So there's a lot of future directions in terms of patients getting treated, but also very important research questions that involve comparisons between the imaging modalities, characterizing the type of problem you have. So as you can see, there's so many variants on the venous side. Wouldn't you like to know that if you have the type of malformation that comes from the bottom up and stops, that you have a good chance of getting better if you're treated? Well, you won't know that until enough studies have really been done that you can say, okay, I did 50 people with that type of problem and 50 more people with the problem of a long, narrowed vessel, etc. Put all that together, and then it'll be much easier in the future to be able to tell people, okay, you have a higher chance to recover if you have that condition, etc. So you can see that research will still be a very important part of this, and from that perspective, the neurologists have a very good point. It is important to follow through with this, and hopefully, as an MS population, you can also get involved with that, and from what I can see on Facebook, even help drive that, and so that you're involved in the process as well. So finally, I would just say if you haven't visited the site ms-mri.com, I think you might find it interesting. One of the things that we would like to do is to collaborate with people like Dr. Sclafani. We're already collaborating with David Hubbard, and I'm hoping in Detroit here, Monty, we will one day be able to do this. The irony is, here we are in Detroit with some of the best neurologists in the world, and they're not working with us yet. Hopefully, they will change because the evidence is becoming so strong, it's going to be hard not to believe it. And so at that point, we could perhaps do a better job here in Detroit as well. But I think the key is to take these sites from around the world, bring people together, and create a database where we can answer those questions for you. So that's enough for me. Thank you very much for listening. So let me bring up the other presentations, but maybe while I'm doing that, if you have any particular questions. So I think David, no, Sal, are you next? Okay.